Today we're going to talk about the blood supply of the brain spinal cord. And over here on the left, I think it's pretty easy for you to see some of the trinkets that we're selling in the anatomy department, showing the circle of Willis. We need this to be able to pay everybody in anatomy. In the middle, you can see something that every medical student should know, the cranial nerves on the ventral surface and some of these beautiful vessels that we're going to talk about today. Over on the right is a unique dissection that I did the other night showing something called the great arterial vessel of Adamkiewicz, and we'll hear about this later in the lecture. This is on the ventral surface of the spinal cord. And we're going to talk about the blood supply of both the brain and the spinal cord, which of course is really important. This shows that the blood that's supplying the brain travels in both the vertebrals coming up here, you can see them right here, and the carotid system. And the vertebrals are going to supply the more posterior parts of the brain. We call this the posterior circulation, so it's going down into the spinal cord and brainstem and some cortical areas, and most of the other areas are getting it from the internal carotid, which branches and supplies lots of cortex, the retina, things like that, and we'll talk about that. You can also see the differences in the amount of blood going through the carotids, which is much larger than the vertebrals. You can also see right here this classic diagram. You should know all about the vertebrals coming off the subclavians, the carotids. Think about a embolus or something nasty coming up through here. It's a straight shot up to the brain. If it goes this way, much harder to get up to the brain due to this right angle right here. So you can think about that. Look at the size of the common carotid versus the vertebral. And this has a little something about the things we were just talking about. Now, Willis, of course, described the circle of Willis. He was an Englishman, and he also, interestingly, described cranial nerves. So he's a very, very famous guy, and you should compare Willis's picture with other famous pictures you've got in your course book, like Carl Brodmann and Broca, Wernicke, and all those famous guys. Here's a good looking circle of Willis. Everybody should know these vessels. You should know that all these vessels lie in the subarachnoid space, and that probably most circles of Willi do not look like this, shown in the next slide. It's not in your course book, but you can see up at the top left there, the anterior communicating is very skinny. Top right would be the anterior cerebral. Bottom right would be, looks like posterior communicating, and then bottom left, posterior communicating, and bottom right looks like what's that look like? A posterior cerebral. Wow. So you can just think of that. These are all probably still considered relatively normal. Now back to here, we're going to start talking first about the posterior circulation. And by the posterior circulation, I mean the vertebral arteries coming up here, all right, coming up into the basilar. Look at that. It's called the basilar because it's on the base of the pons. Here's cranial nerve 6. So you should think about what cranial nerve 6 is doing. Look at this gorgeous trigeminal. Think about the little holes that these various branches go through. Here's a gorgeous 7 and 8. Think about, what if I want to know about deafness or nystagmus, or if I did a Rinne test or a Weber test, I could ask all kinds of things there. Cranial nerve 3 is super important. You can see how it's kind of wedged in here between the superior cerebellar artery and the posterior cerebral. Here's your posterior communicating right here. Here's your optic tract. So think about a little aneurysm of the posterior communicating. I put pressure on the optic tract. Think, would you or would you not have a relative afferent pupil defect? Here's your optic nerve. Look at the relationships here of the carotid, and here's your anterior cerebral going over the top. So think about all these. Haven't heard much about the olfactory tract, but we will, and you'll hear about the uncus too. But we're going to talk about the vertebrals here, and we're going to talk about the basilar, superior cerebellar, and also then we're going to move up into the posterior cerebral. Here's your basilar pons, so think about everything that's in there. This would be medulla down here. Now this shows the vertebrals. I think it's really good. You can see the vertebrals coming off the subclavians, And you can see them going up to the osseous portion here and then hooking around and busting through the dura and going up in here into the medulla. This is another good one here. Look at this. Here's your vertebrals right here. This we call the extraspinal part of the vertebral. Here would be the osseous part. And then once it gets in here, you can see here's probably one of the most important ones called the pica, posterior inferior cerebellar artery. You can see there's no pica on this side. That the pica is going to branch off this AICA, anterior inferior cerebellar artery. Here's your basilar, superior cerebellar, posterior cerebral. Here's a beautiful cerebral peduncle in the midbrain. So think about what would happen if I just kind of put a little lesion here in the cerebral peduncle. Think about those corticospinals and those corticobulbars. My goodness. And then again, think, is this the right or left? If we're looking at the ventral surface here, this would be the right cerebral peduncle. So this is the midbrain, the pons, and the medulla. And I know you've forgotten this, but try to remember it. Here's the cerebellum right there. This shows the vertebral arteries. I like it. Coming up to the osseous on this wicked posterior twist here. And what happens is if you turn your neck too far to the left or right and pinch these in here, especially if they've thinned out or you got a problem in it, then you can blank out. Actually, think about it. If you twist your neck too far, you can pinch this further, and then all that blood that was going up that vertebral to your brainstem is gone. I think this is a good diagram here. I know none of you have seen any anterior arteriograms yet, but here comes I think it's the left vertebral. Here's that little posterior flip, and right in here is something called a pseudoaneurysm, little bulge, a little weakness. And think about any movement by turning your head on this. Think of what would happen to the blood going up here, and especially the blood to the brainstem. A little bit later, this is a little bit later in this patient, and it's better. But what brought this patient to the doctor was they were blanking out, passing out when they would twist their head, and because this blood supply coming up the vertebral to the brainstem was interrupted. So here's a vertebral coming up. Here they come, right there, and we should know these little guys in here. This would be the pyramids. Here's your olive right here. Here's your basilar pons, okay? Here's your cerebral peduncles, okay? And again, the ones we've talked about, here's your vertebrals coming up, forming the basilar, right about where the pons becomes the medulla, a little bit rostral to it. So here's your vertebral. Now, right about here, we have two little branches that come off the vertebral that are going to form a single vessel on the ventral surface of the spinal cord called the anterior spinal, right there. Now also coming off the vertebrals right here and right here are two vessels that are going to go down on the dorsal surface of the spinal cord, and we call those the posterior spinal arteries. And we're going to look at these right now. Now, what's the take home here? This is pretty complicated. Here's your ventral view right here. This is not in your course book, I'm sorry to say. Here are your vertebrals here, right in here. Here's your basilar, superior cerebellar, posterior cerebral, posterior communicating. Coming off the vertebrals, you can see this anterior spinal coming down. Goes all the way down the spinal cord. And the main point here is that as this anterior spinal comes down, it's reinforced along the way by vessels that come from the descending aorta. So in other words, what comes off the vertebra right here is not enough to feed this entire spinal cord. It needs help along the way from these vessels that are coming from the aorta. And this input to the anterior spinal is irregular. It's not at every level. Sometimes there's more on the left, sometimes there's more on the right. It's very irregular that we're going to see. Now you can also see over here for the posterior spinals a little bit more. First of all, you can see two vessels, right? Two posterior spinals, and it also is getting help along the way from these segmental branches that are coming off the aorta. Okay? But the dorsal posterior spinals or the anterior spinals can't do it by themselves. That's the point. Now let's look at how some of this input from these segmental arteries and in the thoracic cord is going to be from those intercostals is organized. This is really great. I found this, I Googled this, I found this, and on the left here is important because you can see the aorta. And coming off the aorta, you can see some of these segmental vessels here. See these? And right here would be the vertebra. So what's the take home here is that the descending aorta gives rise to vessels, segmental vessels, in this area, intercostals. And there's not one at every level usually, but these intercostals are going to help feed the spinal cord. And therefore, they're going to help feed both the ventral spinal or anterior spinal and the dorsal spinals. So blood coming out of the aorta is going to eventually feed into the anterior spinal or the posterior spinals. Now, this is even more critical over here because it gives a big JKH take home. And that is that here is some intercostals here, and here's the spinal cord. Now, the intercostals are coming off here pretty regularly, but look, not all these intercostals supply the spinal cord. You can see that there are some vessels coming off here to the ventral surface of the spinal cord, but not at every level. So there's an intercostal, okay, lots of intercostals, but not every intercostal helps feed the posterior spinals and anterior spinals. So why don't we just kind of look at one typical intercostal, or you can call them segmentals, intercostals. Let's look at one typical one. Okay, now orient yourself, because this is not easy, and I want you to take your time and try to learn some of these names. Now, here'd be the aorta. I think that's pretty easy. And coming off the aorta here and here, and you can see it, the aorta's on the left side, a little more on the left. And coming off the aorta here, we'd have these segmental arteries or intercostal. Here's an intercostal, and here's an intercostal. Then this segmental artery has a couple different branches. It has a ventral branch. Remember now, this is ventral. Here's the spinous process. A ventral branch, and it also has what we call a dorsal branch. And then these dorsal branches give rise to arteries that come up here through the interventricular foramen. Some of them feed the roots, the dorsal and ventral roots, and at some levels, they're vessels, and we call these vessels radiculomedullary, ventral radiculomedullary, dorsal radiculomedullary. Here's a ventral radiculomedullary that comes in and feeds the anterior spinal. You can also see in this typical section here, here's a dorsal radiculomedullary that comes up and feeds this posterior spinal. Here's one on the other side that feeds this posterior spinal. So you have the segmental intercostals that split into a ventral branch, a segmental ventral branch, and a dorsal branch. Dorsal branch is a little more important because at some levels, after feeding the dorsal roots, it breaks into what we call radiculomedullary vessels, and there's one ventral and one dorsal, but not at every level. This shows it even better. The aorta now is on the lower part of the slide, and you can see the intercostal coming off, and then there's a ventral branch and a dorsal branch, and then you can see a ventral radiculomedullary artery going up there, and I've labeled it Adam. This is the great artery of Adamkiewicz. This is one of the largest one of these radiculomedullary arteries and actually feeds much of the lower thoracic and lumbar cord, and I'll show you that. You can see this radiculomedullary artery coming in and feeding the anterior spinal. Now, there could be one going over the dorsal surface and feeding the posterior spinals on the other side, but they're very irregular, very irregular. This again, this really shows, this is one I'll probably put on the exam because it really shows, here's the spinal cord. Now, what's the take-home here? The take-home is that the anterior spinal, the ventral spinal, the dorsal spinals, do not have enough blood as they come off the vertebrals to feed the whole spinal cord. It needs help along the way from these segmentals, and these segmentals are very irregular. Look at this segmental here, the Adamkiewicz. This is a ventral radiculomedullary artery that's feeding, gosh darn this thing, feeding this whole area, this low thoracic lumbar spinal cord down here. Look at this. Here's another one here, but look how vulnerable this region is. You don't see them all the way down. This one right now, think about somebody in there doing surgery. They're doing some thoracic surgery and they nick this. And therefore the person becomes paraplegic. Think of that. So this Adamkiewicz is very important. Here's another feeder here from the lumbar artery. So what's the main point? The anterior spinal can't do it by itself. The posterior spinals can't do it by themselves. There are segmental arteries that come off the aorta, like the intercostals, that have branches that can feed the anterior spinal and the posterior spinals, but it doesn't happen at every level. It doesn't happen at every level. Very irregular. This great radicular artery of Adamkiewicz comes off on the left side more often. Here it is. You can see it comes off more often between T9 and T12 on the left. And you can see it here. You can see here comes one of those intercostal arteries. And look at this thing. It comes in, ascends, and then there's what they call a hairpin turn. So look at the anterior spinal here kind of petering out with blood, and then all of a sudden it gets a reinforcement from the aorta, Adamkiewicz. And then look at this. This is okay. So think about the fact you went in here and somebody's doing some surgery and they nick this. This whole spinal cord, especially the ventral 2/3, is going to lose its blood supply. Now this is what you see in most textbooks. If you're doing a national board textbook, you might just see a cross section of the spinal cord like this, showing the anterior spinal getting the ventral 2/3, the posterior spinal, two of them getting the dorsal third. But you know it's not quite that simple. But think about what would happen if you lost the blood supply via the anterior spinal. Well, you're going to get the ventral horn. You're probably going to get the most of the LCST. You're going to get all the ALS. Now think if you lost posterior spinals up there, it's mostly dorsal columns. So think about it that way. It's not quite as simple as this slide shows. Now, here we're going to move up a little bit, or rostral, but let's take what we know if you were to look at this on some type of quiz. What would I expect you to know? Well, let's just say I pointed it to the anterior spinal, and I could say, maybe the question would be, this blood vessel takes care of the ventral 2/3 of the spinal cord without any help. Well, that's not a good question. Oh, here's one. Vessel is major blood supply of the spinal cord. That'd be false. Okay. Here's your vertebral coming in here, joining the basilar. Here's your brainstem in here, medulla. Here's your pons. Here's some cranial nerves you should know. And then we're going to see some vessels that are supplying the cerebellum and other parts of the brainstem. Now here's probably the most important one, called the posterior inferior cerebellar artery, because it gets the posterior inferior part, but it also gets a really important part of the lateral medulla. Remember Wallenberg syndrome or pica syndrome, which I'll talk about in a minute. So this pica is really important for this part of the brainstem and the cerebellum. The vertebrals move up like this, basilar. Now you're going to get something called the ICA, anterior inferior cerebellar artery. It too is going to get some of the brainstem and the cerebellum. Here's cranial nerve 6 right here. Here's 5, 7, probably 9 and 10. Here comes the basilar. Look at all these little vessels feeding the basilar pons. Think about what's in the basilar pons. Oh my goodness. All those corticobulbars, all those corticospinals. Well, not all the corticobulbars, but you have to be careful on what level you are. But all the corticospinals, You have cortical bulbars in there, you have cortical pontines in there. So these vessels coming off the basilar are feeding those important areas of the ventral basilar pons. Here would be the superior cerebellar artery, makes sense, superior cerebellar, and then you have the posterior cerebral artery right here. And you can see it coming up laterally here to the midbrain. You should know that this is a cerebral peduncle here, that this little designation would be the substantia nigra. You should know the rubber-duber is right in here. Here's the aqueduct. This would be the superior colliculus. You might want to remember that a bilateral tumor here of the pineal would give something called Pernaud syndrome. You should think about if you interrupted all these cortical bulbars here and all the cortical spinals here. Let's do it one more time. Contrahemiplegia, yes. Which way would your tongue go? Tongue would go contra, uvula stand tall, face would be weak contra below the eyes, and the jaw would be nice and straight in the midline. So you see it comes back and haunts you. Here's the cerebral peduncle, here's its blood supply. So you can see that if you lose some of the posterior cerebral, which we're going to see, there are vessels coming out of this posterior cerebral here that are going to come up in here and supply the cerebral peduncle. So you say, well, I could say, well, what if you had a little occlusion of this vessel and all of a sudden those cortical bulbars are going to come back to haunt you. Here's that good looking cranial nerve 3 coming out of here. So here I'd say pupil big or small, you should get that. Lid up or down, you should get that. So you see I can, and then if you open the lid, what would the globe look like? You'd say down and out. Any atrophy, I'd say yes. I could come back in here at cranial nerve 6. I could say which way is your eye deviated, which way you're going to rotate your head, any lower motor neuron, any problem with the opposite medial rectus if you had a lesion of the nerve here. So there's some things in neuroscience that keep coming back to you. When we have the blood supply here, a pica down here, which I'm going to go over in a minute, you're going to have to think about where in the, what's going to happen if you blow out the lateral medulla. You're going to have an ipsilateral loss of pain and temperature from the face, a contralateral loss of pain and temperature from the body. You're going to knock out nucleus ambiguus, so your uvula is going to go contra, and you're going to have a Horner's, which is going to be on the ipsi side. Oops. So here we go again. We're going to take some cross sections here. We're going to just go right up through here. Now here's the pyramid. Here's the olive. This is the medulla. Don't forget that. Here's the anterior spinal. Here's our pica. Here's our posterior inferior cerebellar artery. So we're going to make a little cut in here, and then we're going to see what vessels are supplying some of our favorite regions of the medulla. Oh my gosh, here we are. Here's the olive. Here's nucleus ambiguus. Here's spinal nucleus in tract 5. Here's your inferior cerebellar peduncle. Here's your accessory cuneate. Here's your solitary tract and nucleus. Here's your old dorsal motor 10. Ooh, probably have to dig deep for that. Here's hypoglossal. Here's the good old medial lemniscus, standing tall right there. And here's the pyramid. So you can see, if you lose this area down in here on the midline receives its blood from the anterior spinal artery, which you can see right here. This area, especially the olive out here, is getting it directly from the vertebral artery. And out in here is pica. Here's pica. So don't forget that. So let's say you lost your anterior spinal and you lost your blood supply in here. You're going to have a problem with the medial lemniscus. You're going to have a problem with some of the pyramid here, probably most of the pyramid. If you lost the medial lemniscus, you're going to lose 2-point, etc., contra. If you lost the pyramid here, you're going to have a hemiplegia contra, but no problem with the cortical bulbars because you can see 12 and ambiguous. If you lost the vertebral artery blood supply in here, you're going to have a contralateral incoordination because you got problems with the olive. And then if you get pica in here, look at all the things you can have. Ambiguous, your uvula goes contra. Here, pain and temperature from the ipsi side of the face. Lots of incoordination, lots of incoordination. And what's traveling in here? Ooh, the famous ALS. I forgot about that. So by looking down here at a cross section at that black line there, you can figure out what the blood supply is to some of your favorite structures. And I hope that, you know, these structures come back to you, because by doing the blood supply now, we're refreshing ourselves. Now, some of you might, like Joe, might say, we should have had this when we had the brainstem. Well, I don't know, Joe. I really don't know, because that would have been way too much, way too much. And also, I like to come back time and time again, because you just don't want to have this stuff once. You want to have it time and time again, so that at the end of the course, you remember much more. Let's see, would anybody know what this is right here? Ooh, that's a TTT. Now, somebody's going to ask me, does that get the blood supply from the vertebral, or would it get it from the anterior spinal? I'd guess anterior spinal, but I can guarantee you I'm not going to ask you. I can guarantee you I'm going to ask you this on this exam. I asked you this on exam 1. I'm going to ask you this on exam 2, and I'm going to ask you this on exam 3. So now let's move up forward. We're going to take a swipe, let's see, maybe up in here somewhere. Ooh, right there. And it's our good old level 4. So when you look at this, I know what you're all thinking. I thought we were tested on this. Well, that's not good enough. You got to know it, so come on. When we look at this level, we think about what? We think about the vestibular system. We think about the auditory system, cranial nerve 8. So over here, look at this. This is something called the anterior inferior cerebellar artery. Well, let's go down and find ACA. Well, we're cutting right about here, but here's ACA, and it's going to come back a little bit too. So the ACA is going to get those cochlear nuclei. So you're going to be deaf on this side. Now let's look at this area right here, the vertebral and paramedian branches of the basilar. Paramedian branches of the basilar would be coming off here, and some vertebral. So you can see this is kind of on the midline. Okay, so here we get some of the corticospinals, medial lemniscus, TTT, STT. Then move out here, we still have some pica. And that's going to be hard for you to understand, because here's pica, and again, this doesn't have a pica, but this pica wanders all over the place and actually could go rostral and caudal. So when you blow out the pica here, you're going to get some vestibular problems. You're also going to get some incoordination, spinal trigeminal tract, things like that. So this is a good level 4. I want you to know this one. This one, 7. You know I love 7. So let's go over some structures in here for those of you who've forgotten everything. Down here we'd have the cortical spinals, contra hemiplegia. Cortical bulbars. Well, what cortical bulbars are in here? Those to motor 7 have gotten out. So there's no face problem. So if we had a problem here in the cortical spinals, contra hemiplegia. Cortical bulbars, we don't have to worry about 7. We only have to worry about the tongue. The tongue will go contra. So we have contra hemiplegia, contra tongue. Uvula would be straight. No problems with the face, no problems with the jaw. We move up in here, we got the Fab 4, don't forget that. Here'd be the PPRF. Here's abducens. Remember, some of abducens has cells that come right out the nerve. Some have cells that send their axons up the other MLF. We have motor 7 that loops up and over and goes out to the muscles of facial expression. And you can see here, long circumferential branches of the basilar. That just means, versus the paramedian branches, a paramedian branch would just come up the midline if it was a paramedian branch. Circumferentials come up and loop around. Here we have the short circumferentials of the basilar, but it makes sense. We're right about in here. And then on the midline, we have the paramedian branches, para, next to the midline. So you can see this paramedian, wow. You can have cortical bulbar problems that involve the tongue, and cortical spinal problems too. Move up in here, Fab 4. Wow, look at this, paramedian branch. Here's your big basilar right here. Now we're moving up a little further rostral. This is kind of hard, but we're at the level of the trochlear, right here. Trochlear nucleus, remember the trochlear went up and over? And here's our rough section here. Here's the cerebral peduncle down here. So still we got lots of basilar, paramedian, short circumferential basilar, and then if you come out here, long circumferential circumferential, basilar, and the superior cerebellar artery, which is right about here. See this? So here's your basilar. Here's your superior cerebellar. Here's your posterior cerebral. Here's your cerebral peduncle. Ooh. Anybody know what this is? This is the flocculus. The flocculus. Now, if I had a lesion in the left flocculus, the only thing I have in the left flocculus are Purkinje cells. If I lost all the Purk cells in the left flocculus, my left vestibular nucleus is no longer inhibited, and it's going to be firing like crazy. I'm going to stumble to the right, and I'm going to have nystagmus to the left. Remember, the only thing you have in the flocculus are Purkinje cells that are going out to its surrogate deep nucleus, the vestibular nuclei. All Purks are what? All Purks are inhibitory. So if you lose its inhibition on this vestibular nucleus, it's going to fire like crazy, and the vestibular nucleus on this side will be in control. Now we're cutting up in the midbrain. Here's the cerebral peduncle. These are the smart peduncles. And we're cutting right through here. So here's the cerebral peduncle. Here and here. Okay. Nigra, rubriduber, Fab4, brachium of the inferior colliculus, STT, ocular motor. Ooh. Edinger-Westphal den, somatic, periaqueductal gray, aqueduct, third nerve. So just think about now we're cutting right through here, and a lot of the branches coming out of this posterior cerebral are going to feed up into this midbrain. And you can see paramedian branches of the posterior cerebral are going to feed in there, short circumferentials, and even some of the superior cerebellar will go over the top of the midbrain here. So I think that probably this one will be the most important one right here. But even though the name posterior cerebral, it's still getting the midbrain here, and it also gets the thalamus. Okay, wow. Now we get to, so this is really great. Most of you from Dr. Ulrich's lectures have not heard about the tonsil. And this is just this caudal part of the cerebellum here that can sometimes herniate down through the foramen magnum. You might see that term. Here's the cerebellum on the midline. So this would be the vermis area. This would be the medial zone, looking at it from this way. Look at this pica. Pica comes off, and look how it wanders around. Look at well, it gets all over the place. But you know it here, especially for lateral medullary syndrome. You should know all these cranial nerves here in relationship to these vessels, especially, look at 3. Posterior cerebral, superior cerebellar right here. Anybody got any idea what this is right here? This is probably the posterior communicating. But look at this. Look at these vessels leaving the posterior cerebral. Now, probably most medical students will remember that posterior cerebral is going to go to visual cortex. Okay? But on its way there, it's going to supply, look at LGB, lateral geniculate, medial geniculate, thalamus, vessels coming off the posterior cerebral, going up into the thalamus. Very important stuff right here. Dave Van Lieshout will talk about this later. So know this one. I think this is one of the greatest pictures that there is. But this, it's in your course book. I don't know why I got into such detail. I went into more detail on this. I wouldn't worry about it. All right. Finally, let's go here. We're almost done with this vertebral basilar circulation. Lots of questions I could ask here. Lots of questions in here. And let's see. Here goes that posterior cerebral. Now, don't forget, it's going to supply some other structures than just this. But look at this. Calcarine. Does that ring a bell? Calcarine fissure, upper lower bank of area 17 of Brodmann. This is very important. You occlude this right in here, it gets pinched. Look at this. Visual cortex is gone. You lose this posterior cerebral, you're going to have a contralateral, homonymous hemianopia with no relative afferent pupil defect. Contralateral, homonymous hemianopia. All right, now we're going to talk a little bit about the internal carotids. And here we go. We're going to go up into here, and we're going to look at the anterior cerebral, middle cerebral, ophthalmic, anterior choroidal, things like that. we pretty much have covered the vertebrals. You can see how it kind of goes. We're showing here the posterior cerebral artery, which is the terminal branch of the vertebral basilar blood supply. I like this because it shows spatial relationships that you probably know from gross anatomy. But let's just concentrate on the internal carotid coming up in here like this, and then it does some little. It has different parts. You know, this is a petrous bone here, and you've got probably lacerum coming up through here, and then where it goes through the cavernous sinus and loops up by the anterior clinoid process. And it'll eventually branch into an anterior cerebral and a middle cerebral. It'll also give a branch called the anterior choroidal. Posterior communicating is right here. Okay, here's that ophthalmic right there. Ooh, that's a branch of the internal carotid. Goes through the superior orbital fissure, and you can see it here. It's going to supply the eyeball. And you should be able to integrate this. If I had a little lesion right there and asked you what part of the retina is losing its blood supply, what would you say? Well, all the retina, because the ophthalmic will branch into central retinal artery and posterior ciliaries. Okay, but remember, it's going to give rise to the central retinal artery, which gets the inner part of the retina. Posterior ciliaries get the outer part. But here's the ophthalmic, which is just a branch of the internal carotid. And you can see it over here from Dr. Ulrich's handout. This shows the central artery coming in. All right, remember, it's a branch of the ophthalmic. It's going to get the inner layers of the retina. The next branch off the internal carotid here, before the terminal branches of the anterior cerebral and middle, would be the anterior choroidal artery right here. So here's your ophthalmic, here's your anterior choroidal. This is kind of a interesting small artery. You can see it here. This is not the best diagram, I agree. But you can see it right here, anterior choroidal, coming back like this. See this? Coming back and feeding. Here's the midbrain. Here's rubber-duber and all this kind of thing. You can see that anterior choroidal coming back into here, and it's feeding a lot of the internal capsule, and it's feeding like some of the thalamus, like the lateral geniculate body. This is better. Yeah, this is much better. It's a small vessel, see? It's a small vessel right here. Here's your posterior cerebral. So here's a small vessel called the anterior choroidal. It's also a posterior choroidal that comes off the posterior cerebral. But I want you to know this mainly because it supplies part of the internal capsule. And we haven't had much on the internal capsule, but let me show you what I want you to know here. Come on, anterior choroidal. Now this is kind of a schematic diagram, and we haven't spent a lot of time on slides. But you have had motor systems, so you should know that caudate, lenticular, and things like that. Here's the thalamus, and here's the internal carotid, and here's the anterior choroidal going off, and this big thing is the internal capsule. So think about this as what I would call the posterior limb of the internal capsule. Every cortical spinal fiber is in here. And you can see that this posterior limb of the internal capsule gets some input from the anterior choroidal. It also gets some input from these lateral stripes, lenticular stripes. But it's not going to matter whether or not you lose blood in these lateral stripes or the anterior choroidal. Any axon coming through here is going to be killed if you blow out your anterior choroidal or these vessels here. So because it gets this posterior limb, and because the posterior limb has the cortical spinals in it, it's really important, because if you blew out your anterior choroidal right here, you're going to have a contralateral hemiplegia. Well, granted, you're still going to have this blood supply, but this is going to kill lots and lots of axons. So there's a dual blood supply, and the anterior choroidal is really important. It gets the more ventral part, but you would have a contralateral hemiplegia. This shows the anterior. I'm going to talk a little bit about the anterior cerebral right here, because we talked about as the internal carotid comes off, it gives off the ophthalmic, then it gives off a posterior communicating on both sides, and then it gives off this anterior choroidal, and then it branches into the middle and anterior cerebral. And over here, you can see that. You can see the anterior, here's the middle cerebral, going out to the lateral surface of the brain. Anterior cerebral going over the optic nerve is going to head up the midline. You can't really see that yet. But look at these little branches here coming in. These medial striates and lateral striates. Here's the middle cerebral with these lateral striates. Here's the anterior cerebral, just as it comes off the internal carotid, giving these striate arteries that come in here to the caudate, some of the internal capsule, and to the putamen. And these are long, slender arteries that get plugged up very easily. So we're talking about anterior cerebral. Let's keep going. Now I'm talking about these lenticulostriates, these long, thin ones here. These cause you problems. You can see what could happen, right? These are long and thin, and they're getting fed by a thick artery, either the anterior or middle cerebral, and these become occluded, and we call these lacunar infarcts. Lacunar infarcts. You can see when you're getting around the caudate and putamen, you're going to have movement problems. You're getting into the internal capsule, you could have a hemiplegia. Now, I wanted to show you some of these lacunar infarcts. See these little things right here? Isn't that amazing? These little cysts-like, if you have a problem with these, you're going to get these lacunar infarcts. And you can see, here's some of these little cysts. Oops. Oh, crap. Hang with me, guys. I'll try to get out of here. No. There. Here are the lacunar infarcts. And you can see the putamen, the hippocampus, and some other things like the internal capsule. All right. Now we're going to continue with the anterior cerebral artery, and I'll try not to use this dumb form. You can see the anterior cerebral artery going up the midline here, ACA. Goes up the midline, goes in front of the corpus callosum there. So you see it's getting the medial wall. That's the medial surface of the hemisphere in the rostral part. So it's going to get the anterior rostral part of the prefrontal cortex, goes up onto the medial wall, and the structures on the medial wall that you might know and should think about if you have occlusion of the anterior cerebral artery is going to be like the supplementary motor area. Also, the primary motor cortex and the primary sensory cortex on the medial wall would be the foot and leg. So if you blew out your anterior cerebral artery, you're going to have problems moving your contralateral foot and maybe your leg, and also feeling from your contralateral foot and leg. So think about the anterior cerebral as going up the medial wall. Remember also it gives off some branches to the putamen and caudate and internal capsule. This shows it even better. It shows the blood supply from the anterior cerebral hitting the medial wall pretty far back, so rostrals to the right. Then you can see the blood supply of the posterior cerebral gets a lot of the inside the medial surface of the temporal lobe, but also gets back there by the calcarein fissure. So when you're thinking posterior cerebral, you're thinking area 17. When you're thinking anterior cerebral, you're thinking the leg area of the primary motor, primary sensory, and SMA is on the medial wall. Don't forget that. And then further to the right there, that's all prefrontal cortex. That's where that big tamping iron went up through the prefrontal cortex to Phineas gauge. That would be anterior cerebral. Now let's talk a little bit about the middle cerebral. I always tell students, if you're going to guess on blood supply, say you don't know anything about blood supply, and you have it on an actual board exam or any kind of exam, and they ask you some artery, you say, guess middle cerebral. Just, if you don't know, always guess middle. Don't guess anterior. Guess middle cerebral. You can see it over here on the right. I'll try to use this pointer. Let's see what happens here. There it is. Remember we talked about the anterior? Oh, look at this cavernous sinus. That is beautiful. And of course you should know these nerves going through here. Okay. But anyway, here comes the internal carotid. It splits, gives off the anterior cerebral, which goes up the midline. It does have some striate arteries. And then this big middle goes out through here. Look at that. This is the lateral fissure. You can see lots of lateral striates coming out here. And then you can see some of it goes over the top of the insula and then out onto the lateral surface of the hemisphere. So now you can see this is going laterally. This anterior cerebral is going medially. This is a great slide. This shows middle cerebral. And most clinicians divide it up into a superior distribution up in here and an inferior distribution down in here. So you can see the inferior coming down would like get Wernicke's, superior would get like Broca's, would get primary motor, primary somatosensory. So think about these two divisions and think about all the areas that we taught you, that all those areas in here, like here's your prefrontal cortex, raphidius gauge, working memory. If you're on the right side, you'd have neglect, Gerstmann syndrome, on the left side, well, we are on the left side. Gerstmann would be back here, neglect would be if on the right side, Broca's on the left, Wernicke's on the left, okay? Think about the superior division and this inferior division of the middle cerebral arteries. Now, I like this. Here is a very diagrammatic way of showing the projections from the lateral geniculate deep in here that are going back to visual cortex on the medial wall. So you can see right here would be Meyer's loop. It's going to the lower bank, and this is the upper bank of the calcarein. And most of this, you could see how a middle cerebral problem could interrupt these axons out in here, deep in the temporal lobe, deep in the parietal lobe, before they ever got back there. So think of a lesion out in here that's deep enough to affect this lower radiation, and something up in here deep that gets this upper radiation. And then compare it over here with the distribution of the middle cerebral artery. This again shows the middle cerebral artery in white, shows the anterior cerebral, and the posterior cerebral. You know, it depends on which diagram you look at. Now, here it's got the anterior cerebral coming over the midline, pretty much. I've seen some that don't have any distribution over the midline. But I still think it's safe to say that something like the thumb or the face would be supplied by middle cerebral, and leg and foot would be supplied by the anterior cerebral. This shows the ventral surface. Look at that posterior cerebral. In addition to getting visual cortex, it's going to get much of the ventral surface of the temporal lobe. You can see the anterior cerebral get some of the midline up here in the orbital frontal cortex. Deep in here is the hippocampus. So think about all the hippocampus making our memories. Posterior cerebral artery supplies its blood. And that's very, very important. Don't forget that. We haven't had memory, but we will. Now he's talking about the middle and anterior, and what happens is sometimes, let's go back to this one. Well, maybe this one. Sometimes the blood, you go into shock or have a heart attack, and the blood pressure goes way down, and the blood supply is affected, and you think, well, here's your middle cerebral, but there's less blood flowing here, and there's less blood flowing here too. And the regions in between here are going to get the least amount of blood, right? This is clearly going to get blood, but it might be that these regions in between we call the watershed. If you have less blood here, and this is the area, who knows how far this goes? Who knows how far? Maybe it's sharing. But once you don't have it, then you can have an infarct in your. Anytime you have a heart attack and the blood pressure or the blood supply is reduced, and you get something called a watershed infarct. And here, especially this one, here's a watershed infarct between the anterior cerebral and the middle. And you look up in here, look at this dead area in cortex. So this was supplied by anterior cerebral. Here's the watershed infarct, and this is middle. So kind of the area that's supplied a little bit maybe by both has the infarct, called a watershed infarct. Now let's do some angiograms. This is the part that would be like pulling teeth. And everybody tells me, oh my gosh, I can't do these angiograms. Every year I hear this, but let's try to do some and realize that I'm not going to test you like you're in a neuroradiologist. But what happens is they can inject dyes in your bloodstream, and they can pretty much put this little injection anywhere they want. They could put it in your carotids or in your vertebrals, or they could put it in the smaller vessels, and then they can eventually see where that dye went, and they can light up your vessels. So even here, you've got things labeled here. Here's a vertebral, here's a basilar and a pica. Okay. Here's your posterior cerebral. So this is just a little way to get you excited about angiograms. We'll go through some of these. Now, here they've injected the vertebral. We're looking at it from the lateral surface, and you're going to say, oh, how am I going to know that's the vertebral? Well, does anything would the internal carotids go up like this and loop around near the atlas? I didn't even label the atlas. So here you have your vertebrals, and then guess what this is? Oh my goodness. And then, of course, this is the basilar. It's running in this like this, and then it's going to terminate as the posterior cerebral. And remember, I told you some of these vessels coming off the posterior cerebral go up into the thalamus. Well, here we go. And maybe this is even a little piece of the posterior communicator. So then you say, oh, gee, John, if this is the basilar, then I better find the pica. There it is. Now, if I was to label that and say, give me some deficits if I had an occlusion here, you're going to have to think about lateral medullary or Wallenberg syndrome. Here's a little ica. Here's the rest of the basilar. Here's the superior cerebellar. Remember? Superior cerebellar, then posterior cerebral. Now, let's say I included the posterior cerebral here, and I start talking about contralateral homonym hemianopia. Well, that's fine, right? Because you know this posterior cerebral is going to come back here into the striatal cortex, area 17. So I don't think anybody ought to miss this one right here, showing the vertebral, the basilar, posterior cerebral. No way that this could be the internal carotid circulation. Absolutely no way. So I think I'm safe in asking you this. Here's the real thing. Vertebral, you can see, look at that pica. It goes all over the place. Basilar, I would say I could ask you that. Superior cerebellar, posterior cerebral, nobody in this class should not be able to get this. All right. So this is a lateral view. Now we're looking at an AP view, anterior posterior. So here's the orbit right here. Okay. So, if I'm looking at this, naively, I'd say it's probably left. Vertebral coming up, hooks around, and then look at this basilar, right on the midline. Right on the midline, right? Nothing in the internal carotid system looks like this. So vertebral, basilar. Wow, pica, oh, that's kind of hard. Ica, not too hard. Superior cerebellar, easy. Posterior cerebral, coming up to the, look at this, you got to think about this as going back to the visual cortex, to the calcarine cortex. So, nobody could call this internal carotid. Nobody could call this internal. This is the basilar. Especially when I made sure that it's got the pica, ica, and superior cerebellar on it. And then what branches in the middle like this and goes out like this symmetrically in the posterior cerebral. I love this one. Like it should know the lateral and the AP view of the vertebral basilar system. I mean, here's the real deal. Now, notice I haven't labeled everything because, let's see here. Well, I certainly know that this is the posterior cerebral, and I'm just a neuroanatomist. Okay? Calcarine is up in here, the area 17. Basilar is there. I bet I know what that is. It's got to be the superior cerebellar. Now, if I labeled that, you'd have to say ica, I think. And if I labeled that, even though it's weird looking, you'd have to say pica. Maybe I should just label this, and this, and make everybody happy. All right, let's move on. Now we're looking at the internal carotid artery injection. They put some dye in the internal carotid. Now, does this look at all like the vertebral basilar? Not at all. Look at this thing. I always go left, right, left, right. I mean, this is the internal carotid. Nothing in the vertebral system looks like this. You see the atlas down here? No. There's a sphenoid sinus. You know what's going on here. This is the internal carotid. Now, here you can see, gosh, they've got a posterior cerebral artery coming off it. Well, that's the way it goes. Sometimes it happens. But all this is the anterior cerebral on the medial wall, and a lot of this would be lateral. Or this would be anterior cerebral and middle cerebral back here. I don't think anybody. This right here is called pericallosal. It's going up over the corpus callosum. I can see that. I know that. So I know that this is the anterior cerebral. This is anterior cerebral stuff up here. Here's middle cerebral stuff back here. Anterior choroidal, I'm not going to answer that. But if I told you that was, I say, this vessel's anterior choroidal, and I got a lesion on the left, you should know it gets the ventral part of the internal capsule. And if you get it on the left side, you're going to have a right hemiplegia. Ophthalmic, I could ask you something about from Dr. Heatley's or Dr. Ulrich. Okay, I could ask you, if you lost this artery here, say it's left or right, doesn't matter, left or right, then I could get into that relative afferent pupil stuff, because you're not going to see it against the eye at all. So you are going to have a relative afferent pupil defect. So this is a lateral view of the internal carotid injection. And here's the real thing. Well, all I would start thinking about is, oh my gosh, what this guy doing to me? But this is, here we go, all those little curlicues of the internal carotid, petrous lacerum, cavernous part, all right? You can see the posterior cerebral is coming off the internal carotid. In this case, middle cerebral, pericallosal would be a branch of the anterior cerebral. Orbital frontal, so the orbital frontal cortex. Ophthalmic, very good, very good. Now, you go back in here and start looking for that anterior choroidal. I wouldn't know. I wouldn't expect you to know either. But I would expect you to know that the internal carotid artery was injected with the dye. This is not the vertebral basilar system. And this is a lateral view. Now, here's an AP view. Certainly, could not be confused with a vertebral basilar system where they're always looping around. And there's the ophthalmic, come on, going up the midline. Sometimes it fills on both sides of the anterior cerebral. That makes sense. You wouldn't see this if you injected if this was the vertebral, it'd come up like this right on the midline, and then it'd branch into two posterior cerebrals. So this is internal carotid. Here's your anterior cerebral. Okay. I lost this. What part of your body can't move? Foot, leg. I lost this. Do you lose any planets? Yeah, supplementary motor. And you go out here. There's the anterior choroidal. That's tough. I wouldn't have said. Here's middle cerebral. Gee, I lost this on the left. Would I have a broken? Yeah. Gee, I lost this on the left. Would I have a Wernicke's? Yeah. Gee, I lost this on the left. Would I have neglect? No. Got to have it on the right. Gee, I lost this on the left. Would I have Gerson? Yeah. That's the way you need to think about these things. Well, let me show you the real thing. Because I know there's a lot of complaining, here I put a comparison. The vertebral's coming up on the midline, branching to two posterior cerebrals. You don't see that over here. This is a real thing. Ooh-wee. Beautiful. Anterior cerebral sometimes fill on both sides. Here's some of those stripes, remember? That are going into the putamen and caudate and internal capsule. I pointed out a few slides back. Here it's heading out the lateral fissure, and then here's that cortical branch going out onto the lateral wall. This is really a good angiogram. And I'll just leave with this. We're going to have 2 lectures on this. A new guy named Dave Neiman. But I want to guarantee you that you're going to see this on the final exam. And because so much is integrated here. You're seeing some of the real heart, even though it's a ventral surface of the brain. And I'll leave you with the basilar artery. Think what would happen if you lost some of those paramedian branches. Posterior cerebral, what would happen if you lost some of those paramedian branches that are going up into the ruber-duber, cerebral peduncle, and then what happens when it doesn't get back to the visual cortex. Anterior cerebral, going up the midline. If you lose that, you're going to have a problem with the concha leg. SMA, here's your anterior communicating. You get a lot of aneurysms in here. What else? Middle cerebral going out on the lateral wall, going to get Broca's, Wernicke's, Gerstmann's, things like that. So I'll leave you here, and I'll talk to you later.